I ask you to give me the list of bodily fluid in human body. Let's count them down. What are they?
Blood,
Blood.
sweat,
Yeah.
serous secretions,
Sweat.
saliva, saliva,
Saliva. Okay. So GI tract fluids.
GI,
generally.
nasal secretions.
Yeah. So pre-GI. Okay. What else?
Urine,
Yeah. I would have expected you got in that direction, blood, urine, but it's good.
Okay.
What else?
are you counting stomach acid in GI?
GI, yeah, GI.
Okay.
Everything in the GI is a fluid.
Pleural
Actually,
fluid?
it's fluid. To pass through, it has to be fluid.
Okay. Pleural?
Pleural fluid. Is it really fluid there?
Isn't it like viscous?
So these are the normal content.
Okay.
Normal. We are going to go to abnormal in there. If there is fluid in the pleural space, yes, pleural effusion, but that's not a physiologic. Generally, it's a very thin amount, but if you truly what you could consider fluid, it's already abnormal.
Okay.
Pleural fluid of effusion.
Like an exudate.
Effusion.
Okay.
So, but let's continue with the normal.
Peritoneal fluid?
As well, you know, there's a very minimum amount there,
Okay.
but if you have a huge amount there, as well is not normal. It's called ascites. You know what that is?
Mm-hmm.
Yes. So it's a peritoneal. Peritoneal. It's not a normal thing. Usually it should be really not much there. What else?
Extracellular?
No,
Not
that's
much.
not a, that's all our bodies from water. That doesn't count.
Amniotic?
Oh, you're going really
That's a
fancy.
very long
What about the
list.
gallbladder?
Okay,
Yeah.
so
What
like
about
kind and bile.
Oh, okay. And there's some few stuff there, like, you know, if you're pregnant, you may have that.
What about
fluid.
synovial?
Synovial, you know, again, again, if there is truly a fluid there, it is not a normal thing. It is a joint effusion.
Joint effusion?
Yeah, joint, and you notice they're separate, right? Joint effusion.
And CSF.
Good. I would have thought you go with blood, urine, CSF, but your order is a little different,
Okay.
but that's fine. CSF. And let's go to pathologic things. You mentioned pleural effusion, ascites, peritoneal effusion, joint effusion. What else doesn't belong there?
Any kind of exudate, any kind of purulence?
Purulent material, infection, purulent and collection. What does it blood called when it's not in the right place? Hematoma. Hematoma. And what else would be there that usually wouldn't be there? You mentioned it before. Serosanguinous, like if you cut somebody, it starts healing. When it starts healing, produces additional juices. And they are called serosanguinous collection. Or we usually just say serosanguinous material. There are some other fancy stuff you didn't mention, like a vitreous thing in the eye.
Inside the eyeball.
That is a fluid, but you know, if you have vitreous stuff, you call the ophthalmologist, you call the ER. You never deal with that, so you don't need to be worried about that. With the bile, when do you have to deal with the bile?
Never.
Never, not in our field. So let's just eliminate things that we don't have to deal with, okay? So you don't have to deal with that. Urine. In our field, you know, obviously we deal with that. We put catheters in. Sometimes I have to do put catheters in. Sometimes we put suprapubic catheters in. Urine is sterile, so you have to deal with that sterilely, meaning that you clean. You use the sterile technique that we will talk about, and we have talked about. We will talk about it more. You have to use sterile technique with the GI, is nothing sterile about it. You do not have to do sterile technique on anything that has with the GI,
Right.
because you cannot add more than it's already there, right? Like when you put a GI catheter, you just shove it in. You don't do iodine prep like you do for urine and so. But generally as well, you shouldn't be dealing much with that part, because what do? We put sometimes we put the stomach probes and so on,
And
nasal
G-tube,
probes and
yeah.
G-tube and so on, but it's not the main part of what we should be doing. So let's just eliminate this and this. That is very fancy thing. Yeah, I wouldn't really call it the bodily fluid because it's not really in the body.
Okay.
So let's eliminate that as well.
Okay.
So you have to deal, and let's go to the bad part. Pleural effusion. Now, most of the time when you do a thoracic thing, it may have some effusion there. We will come back to that later.
Okay.
Now let's talk about the ascites. Usually, it's not considered a good thing if there's any fluid there. It's usually a problem of the liver that pushes the material from the portal venous system to the peritoneal space. So we shouldn't be really, I mean, if somebody has ascites, usually we should think twice about doing surgery. That's a usually a terminal situation. So let's just eliminate that. Joint effusion, yeah, that is a big deal. Bigger joint have bigger effusion. Smaller joint have synovial cysts in the sets, they may have something, but you never have to deal with that. It's a surgery. To get there, to try to take it out, is a surgical thing, so you won't be dealing with that much either. You will be dealing with Serotonin Hematoma and pleural collection. Pleural correction, we come back because we do the thoracic. If you would not do the thoracic surgery like 80% of the spine surgeon, you wouldn't need to deal with that. But Sunny, Kim, and I, we do deal with the thoracic. So you may need to know a few things about the pleural effusion. Yeah, in all of that, the most important thing for you, how would you, by volume that you have to deal with, which one of these, so 1, 2, 3, 4, 5, 6, you think you deal mostly with?
To address.
What is what you will mostly address? No, I hope not. My last
I
infection
hope
was
not.
two years ago.
Okay.
So which one?
Hematoma?
I hope not.
Okay.
Because my last hematoma was like 8 months ago, a year ago. Yeah. Serotonin.
Okay.
And that is by volume, I'm hoping, 98%, 99% of what we deal with is with this fluid. Because we put drains in to suck it out. Now, anything like serotonin, especially hematoma, that get collected in the wrong place, it is a medium that can get infected. So we don't want any of that in. As a matter of fact, there's a huge saying in Latin, actually the Socrates came with that, called obi hoc ibi evacua. You know what that means?
Where they're supposed to get rid of it?
Exactly, good one, yeah. Wherever pus, remove it. So, meaning that if you have an infection, it's anywhere, doesn't really matter. And there's the infection is coming out. Do you make the hole smaller or bigger? You make the hole bigger. Can you give me one of those those wipes, please? We can do it first. So never stop the pus or coolant material to come out. Make the hole bigger, open it up, let it drain, because that is what literally kills the people. People get septic if you prevent the coolant material to come out. What about serotoninous and hematoma? What do you think is the proper thing to deal with that?
What?
If asymptomatic, let it be. Because every time you manipulate, you may introduce it. Yeah, you introduce an infection. Every time you try to take it out, you may introduce a thing. But right after the surgery in a sterile environment, you put a drain. For open surgery, we do it all the time. You put for ACDF, we put it for the lumbar drain. I usually use what we call medium hemovac. Medium refers to the size, and hemovac is just something like a spring inside. You push it in, and there's a connection that goes inside of the body, a big tube, and then it becomes smaller, goes inside of the body. It comes like something like this. You cut one off, you cut your drain that comes out of the patient at an angle, and then you stick it in, and it sticks in just fine. And you just have to cut it at an angle, that drain, but it goes easily. If you have two drains, you can cut this one as well, use that, but it has to be cut.
Okay.
The drain themselves, they come like this. They come like this, and they have holes in the middle, and then there are two lines. And that is for, you can cut it and use it twice. And you cut the drain always between the holes. Look at that. This is the catheter. There are holes.
Yep.
You cut it between the holes.
Yep.
The reason for that is if it breaks, the usual place it breaks is at the hole. So if you take a drain out and you see it at the, it is, if there is a, if you take it out and the drain look like this, mean it broke inside. But because that is the weak spot, that's where it usually breaks. But generally, if you take it out and it looks like that, meaning you are fine.
That's right.
Okay. For the drain, this is my protocol. For open surgeries, I almost always put a drain. And usually I take the posterior drain off when the volume is less than 100 cc for the lumbar and posterior cervical is less than 100 cc. You're recording, you don't have to memorize it. So less than 100 cc in a day or less than 30 to 14 per shift.
Okay.
Usually next day it comes out. Additionally, what is important for anterior cervical drain, the volume is more critical because it can push on the esophagus and trachea and so on. The threshold to take it out is much lower. Like, I don't take it out if it puts out more than 40 cc.
Okay.
To the cervical, anterior cervical. Anterior cervical behaves more like a lumbar.
Okay.
Okay? Now, if the drain has to be sewn in, so it doesn't come out accidentally. This is the skin, this is the drain is coming out. We put a stitch in, and then we put a knot in the air. We call it air knot. And that is the reason is that in the nurses are going to thank you because they can just cut it easier, take it out. Make sure that two lines are not more than an inch out. And then you wrap it around on both sides, and then put another knot, tug on it, make sure it's tight. And I usually, while the patient has a drain, meaning something going from outside to the cavity of the incision, I keep patient on the antibiotic. Antibiotic is usually for 1 day, but if somebody for whatever reason is has 3 days of draining, should have 3 days of antibiotic. While draining, antibiotic stays. Drain output is in the conversation is very important. I always want to know how much you did put out since the surgery in the last 24 hours and in the last shift. That gives us a kind of trend about how to deal with that drain. Now, this is all about obviously cerebellomas.
You write what it looks like when it comes out of the drain?
You can write them, and we know it how it looks like.
Okay.
Obviously, you know what hematoma looks like, and you know, and it can just sometimes somewhere between. It can be both.
Okay.
You know, and you see it. And this is, they can turn into that. Okay? If this is this, if this is this, you try to stop it. Because mostly you don't want anything to have a connection to outside. Hematoma, you don't really care because it's usually solid within minutes. Then after 3 days becomes liquid again. And then in that, if it's causing local problem, you have to have a sterile way, clean it, and then put a big needle in and suck it out. I've done it maybe once a year I have to do it, or maybe every other year I have to do it. If any of that look like a purulent, You don't stop it anymore. You slash it open, you open it up and let it drain. Okay? Pleural effusion, we deal with that in a very different way. When we do thoracic surgery, sometimes, Dr. Kim does open, I do minimally invasively. In about 1 in 10 of my cases, I put a drain in, what we call the chest tube. You have to continuously suck out on that. There is a method of doing that that is beyond this meeting. We will talk about it later.
The like water chamber?
Yeah, it's what we call water seal.
Yep.
And there's water, and there's a vacuum that goes up, and the water seal makes sure that you keep the suction at a certain level. That certain level is usually minus 10 centimeter of water. You have to come back to that when we do a next, because that is a session for itself. So let's talk about now history, very short, very briefly. Obviously, blood, you know where it is, and you know how to access it, venipuncture and so on and so forth. If it's obviously arterial bleeding, you just have to, you don't drain it. You neither do it, I mean, except you are drawing blood from somebody, you don't drain that. So it is really not part of the drain and management of the drain thing, okay? But what you need to know that if there is a connection there, the pressure that is in the arterial side is what is it? What do you think? What's the arterial pressure? Between diastolic and systolic? No, way higher. I would be very concerned if your systolic blood pressure is 30 to 40. It's usually 80
120
to...
over 80 is 40,
Yeah, 120.
40 of a difference, right?
No, but that is still your pressure is not 40. Your pressure is 80 to 120. Meaning that if my foot starts bleeding 120 centimeters, the blood would literally pump up to here. Can you imagine that?
No.
Have you seen that?
No.
I have.
Okay.
The blood going to the ceiling. I have seen that. So you don't really drain that. So it's not part of this conversation.
Okay.
But the idea is in a situation like that, if there's arterial blood, you have to identify the source. You cannot tamponade it. You have to identify the source of bleeding and clamp it, cauterize it. You have to deal with that directly.
Yep.
What is the venous pressure?
80?
14. No, venous pressure, well, we could not do surgery. If venous pressure was that high,
Okay.
all the surgery in human history would be impossible.
Okay.
Because if you would cut and it would jump 80 centimeters,
Right.
so the venous pressure is, as a matter of fact, the capillary is even 4.
Okay.
But truly venous pressure is this. So what's the best way of dealing with that?
Pressure.
Pressure, tamponade. That's it. Even sometimes you just have to pour 4 cc, right? Meaning that sometimes you just can pour some water on it, and the water pressure will stop the bleeding. Okay? Now, and what you see sometimes, what we do in open surgery, we put just laps in. The pressure of the laps is sometimes enough to stop the bleeding. Okay? Now, finally, we come to the CSF. That is a session just for itself. If you have a CSF kind of deal to deal with, who do you call?
You.
Me. Do you call Dr. Kim?
If I have to?
No, you don't call Dr. Kim. If you have CSF, generally, if it's truly CSF, if it's in the spine, yeah. We neurosurgeon deal with the CSF, truly if it's the CSF from the cranial thing. Obviously, if it's from the spinal thing, like a CSF leak and so on, yes, you call Dr. Kim, you let him know, and he can deal with that. But truly, the CSF is a deep domain of a neurosurgeon, not an orthopedic spine surgeon. Okay? But except that, if it's in the spine, and they do a primary closure of that and so on, and if it's Dr. Kim's patient, you have to let him know.
Okay.
Okay? Sometimes, you put a drain in to reduce the pressure there. What is the CSF pressure? Very close to the venous pressure. Actually, 14 is very high. It's about 10, 8 to 10. Okay? So, That is, so pleural thing and the CSF are two different kind of things that I don't believe they have priority for you now, except to deal with if there's a CSF leak. Now, you never drain indefinitely CSF. What happens if you do? You get first spinal headache, then you can have some kind of bleeding in the brain. Do you know what they're called? Huh? The bleeding between the subarachnoid space and the dura is called subdural hematoma. And if you reduce the pressure, the nerve, the veins both burst, and you may have bleeding. So if there's a CSF bleeding, you don't drain it. Okay, you just have to manage it. Okay, but they mostly call me for that. Okay, because it is my domain to deal with that. If there is a CSF leak, what is the rate of CSF leak in open old-fashioned surgery? It is usually considered 8.7%. In some surgeries with 3 Ds, it can be 20%. And what is our rate of CSF leak in OLF? 0. 0, yeah. So in some studies, open surgery is rated at 35%. So we are in a good position that we don't have to deal with that.
What about post-Milo or ESI?
That rate, the needle we use is less than 1%. And then best thing is laying down, drinking coffee, drinking fluid, and just letting it be. Blood patch only if they don't go away.
Okay.
Okay? We should wrap it up now. Okay? So officially, you can let Amanda print that thing out.